But I'm Camron, I'm a genetic counsellor. I'm based at Genetic Health Queensland, which is just up the road here at the Royal Brisbane Hospital. Some of you may have met with us, some may not. So it's a bit hard to put everything about genetics into one talk, but hopefully if there's any time later today, if there's questions, I don't cover anything, just feel free to ask. So I think probably a good place to start is just to give you some information about, I guess, how ovarian cancer usually develops and how that is a little bit different when we talk about a genetic cause. And the first point I like to make is that most of the time ovarian cancer is not a genetic or an inherited cancer. So about 80% occur by chance. And what we mean by that is due to lifestyle and environmental factors causing damage to the cells of our ovaries. Now, it's never one thing a person does or doesn't do in their lifetime, but instead it's a build-up of those factors. And building up those factors take a bit of time, and so by the point we get to developing an ovarian cancer, most women are getting older. So usually approaching their 70s, into their 80s. And when the cancer has developed that way, those lifestyle and environmental damages we've built up, they start off only in the cells of the ovary, so they're not in other parts of the body like the egg or the sperm, and so they're not passed down from parent to child. But what we do know is that about 15 to 20% of the time there can be a genetic basis to the ovarian cancer. And what we mean by that is that for some individuals, what happens is at the time that the egg and the sperm come together, they inherit either in the egg from their mother or the sperm from their father some genetic information that isn't working as it should. And so because of that, they're a step closer to developing cancer from the very beginning, or they're predisposed. It does not mean they always go on to develop cancer, but being that step closer, they need less lifestyle and environmental factors. And because less of those other factors are needed, what we tend to see is they get to that point of developing cancer sooner, so they tend to have a younger age at diagnosis. And also we can often see a family history of cancer that's a little bit stronger than what you'd expect as well. Usually when we talk about genetic or inherited causes for breast cancer and ovarian cancer, usually what we're referring to is what we call the BRCA1 and the BRCA2 genes. Yeah, and everyone starts nodding at that point. There are some other rarer conditions that can cause family histories of ovarian cancer, and one of those is Lynch syndrome, if there's anyone here who's been tested. And there are some other more rare causes as well. But because it's usually what everyone knows, most of this talk focuses on BRCA1 and BRCA2. And BRCA1 and BRCA2, that stands for the breast cancer 1 and the breast cancer 2 gene. And BRCA1 and BRCA2, they are genes or instructions that we all have within our body. So every single female, every single male has those genes in their body, because usually what they do for us is protect us against certain types of cancer. So that for women, they're usually working to protect against breast cancer and also cancer of the ovary. And for men, it protects against prostate cancer and also male breast cancer. So the problem's not having the BRCA1 or the BRCA2 gene, but instead a problem occurs if one of those genes isn't working as it should. So if you have a fault in the BRCA1 or the BRCA2 gene, or what we call a mutation. And if you have a mutation or a fault in those genes and they're not working as they should, then you lose protection to those particular cancers and you're more likely to develop them. So I guess probably the simplest way to think of any genetic testing is simply as a blood test that looks at the BRCA1 and the BRCA2 gene to see if there's a problem or a fault or a mutation in those genes for you. I guess clinically at the moment a lot of our genetic testing is around BRCA1 and BRCA2, but they're certainly not the only genetic causes for ovarian cancer. And the reason I say that is because we do have lots of women and lots of families who have very strong histories of cancer where we look at this BRCA1 and BRCA2 gene and we find absolutely no problems. And in those cases, we're not saying there's no genetic risk in the family, but what we're saying is that it's not due to these genes that we can test for. So there are some families where we do this type of testing, find nothing, and we still worry about a genetic or an inherited risk. But it's probably in a gene that we can't test for yet. So getting on to genetic testing, which is usually what people want to know about. If some of you have had genetic testing, it may have been organised by your oncologist, maybe by your genetic service, or some of you might have looked into what we call direct-to-consumer testing, and I will talk about that a little bit later on. For women who've had their testing organised by their oncologist, some of you may still require referral to a genetics centre in some circumstances, particularly if you've got additional family history of cancer and nothing was found on your test. And the reason for that being is that we can look at that result in the context of your family history and still give you some advice about the risk for cancer for your relatives and also their management options. There are genetic services throughout Australia and across the world if anyone has relatives that live interstate or overseas who are concerned about their risk. Here in Queensland, the public service is Genetic Health Queensland. As I said, we're up the road at the Royal Brisbane. But even though we're located there, we see people face to face both at the Royal, the Sunny Coast, the Gold Coast, Townsville, Toowoomba and Bundaberg. And for women who don't live close to those centres, we also do telehealth, which is kind of like using Skype. And we also do telephone appointments when it's necessary. But no matter who arranges that genetic test, whether it's your oncologist or whether it's the genetic service, before we do any testing, we always make an assessment of your personal and family history of cancer to see if testing will be useful. And what I mean when I say whether testing would be useful is if we do this test, are we likely to find a mutation for you? So because of that, there are national criteria that exist to help us determine if we can publicly fund BRCA testing for you. And so for us to be able to perform that testing with no cost to the patient, there needs to be at least a 10%, if not greater chance of us finding a mutation in those genes. I'm not sure how I'm going for time, but I guess very briefly, a lot of women with ovarian cancer actually do meet criteria for testing. And that's because we do test women diagnosed with high-grade epithelial. So if you know your type of ovarian cancer, that's what we call a serous, an endometrioid or a clear cell ovarian cancer, who were diagnosed at the age of 70 or younger. Women with epithelial ovarian cancer at any age who have breast cancer in a close relative, so that can be a sibling, a parent, aunt or an uncle. Women who are diagnosed with ovarian cancer at any age and who are eligible for treatment with a drug that we call olaparib, and women with ovarian cancer who have Ashkenazi Jewish ancestry. Now, if you don't fall into any of those categories, you can always have an assessment made by genetic service because we do look at the family history as a whole. So if you're not sure if you meet that criteria but you would want an assessment, you can always be referred to genetics and we can do that for you. But if you don't meet the criteria or we do an assessment and the chance is less than 10% and you'd still really like to have testing of those genes performed, it can be self-funded, and at the moment that costs about $400. But usually if we're not publicly funding it, it's because the chance of finding something on that test is really low. If any of you have done some Googling or some researching, there is what we call direct-to-consumer testing. So that's often an internet-based kind of genetic test where they send you out a kit and you send it away. If you Google, they're often cheaper than seeing us in the genetic service, but there are benefits and limitations to that type of testing, and I will talk about that a little bit later on as well. Genetic testing is not sci-fi or weird, it really is just a blood test. So we just take 2 tubes of those purple-topped tubes that you're probably all very familiar with, and the result takes about 8 to 12 weeks, just depending on how busy the lab is at the time. So there are a few things, I guess, that people should probably consider before they undertake genetic testing. It's certainly not an exhaustive list, but people kind of fall into one of 2 camps when it comes to genetic testing. Either they're super keen on it or they're not. And in terms of reasons why you might undertake a genetic test, probably first and foremost in everyone's thought is that it can help target your treatment. The next thought that people usually have is that this can help clarify the risk for future cancer diagnoses. So it doesn't clarify the risk of recurrence, so the chance of an ovarian cancer coming back, but it will clarify the risk for breast cancer, for example, if we find a mutation. Some people have what we call an information-seeking coping style, so like to know absolutely everything they can about their diagnosis and about their treatment, and this is something else that you can add to that list. And for some people, taking a genetic test might relieve some uncertainty about what their risk for breast cancer is in the future, or what the risk is for their relatives as well. And also, another reason people often undertake genetic testing is because if we do identify something on the test, then there is a test available to relatives to help clarify their risk as well. But there are people who decline genetic testing, and that's okay as well. And probably the biggest reason for declining is often when we contact people about genetic testing, it's usually when they're first diagnosed. And as you're all probably very aware, you often have a lot going on at that time. Things snowball really quickly in terms of appointments and specialists, and we're probably the last thing on that list. Getting treatment is sort of top priority. So you've got lots going on, it's not a good time, but those patients can always come back to us in the future if they really want to go ahead with a test at some point. Some people, opposite to information seeking, are avoidant in their coping style, and so they would rather just not know this information. People decline because they're concerned what the result would mean for themselves and their relatives in terms of a risk of cancer. And also, one of the other really common reasons people decline testing is that they have concerns regarding insurance. And everyone always has questions about that, so I do have a slide at the end to address that for you. But no matter which camp you fall in, I guess the role of the genetic counsellor is to meet with us and have a discussion about genetic testing, and for us to provide you with support and some help in making that decision about whether genetic testing is something you'd want to pursue or not. But if you do go ahead with testing, there is 3 possible outcomes, and probably the first and the simplest is what we call a positive result. And what we mean by a positive result is that when we looked very carefully at your BRCA1 and your BRCA2 gene, we did find a fault or a mutation in it. So that result confirms that there is definitely a genetic or an inherited risk for breast and ovarian cancer within the family. The reason I say that's the easiest result is because once we know that there's an inherited cause, we can offer testing to your relatives to see who in the family might have inherited this and who hasn't. And the reason I say who has and who hasn't is because even if a parent does have a mutation in BRCA1 or BRCA2, they don't always pass it on. And the reason for that is because all our genetic, see my hands, all of our genetic information comes in pairs. One half of our information always comes from our mum, and the other half comes from our dad. And you only need to have one copy in that paired image to be at that increased risk for developing cancer. So you only need one faulty BRCA1 in your pair or one faulty BRCA2 in your pair. But what that means in terms of inheritance is that every time we have a child, we only pass on half our genetic information. But it's a random half which half you pass on. So for a parent whose genetic material looks a bit like this, every time they have a child, there's a 50% chance of passing on the faulty copy of the gene and that child being at an increased risk. But there's also a 50% chance they pass on the good copy, in which case that child's not. So finding something on testing really helps us clarify the risk for other people in the family. And I will talk about a positive result in a little bit more detail, but just to kind of keep the flow going, the next possible result we can get is what we call a negative result. And what we mean by a negative result is that when we looked very carefully at your BRCA1 gene and we looked very carefully at that BRCA2 gene, we didn't find any problems. So we didn't find any mutations or faults. Because we've not been able to find any problems in those genes, we can't offer a genetic test to any of your relatives because we simply don't know what it is we're looking for. The impact of a negative result is really dependent on the family history. So in the context of your family history, if you get a negative result on BRCA1 or 2 testing, if you've got absolutely no other family history of breast or ovarian cancer, we're usually pretty reassured by that result. And your relatives are probably close to population risk of developing breast and ovarian cancer. But if you get a negative result and there's still some additional family history of breast and ovarian cancer, what we do is we go back to your family history. We have a good look at the types of cancer people have been diagnosed with and also their ages at diagnosis to make an overall assessment of what the risk is for your relatives and to give some advice about the management for them. There is a third very tricky result that we sometimes get. It doesn't, getting my warning. We sometimes get it, but it doesn't happen often, and it's called a variant of uncertain significance. And what that essentially means is when we looked at your BRCA1 and BRCA2 gene, we did find a change in them, but it's a change we've never seen before. So your gene just looks a little bit different to what we'd expect. But because we've never seen it before, we don't have enough evidence to say that that change does cause a problem, so it's like getting a positive result. But it also means we don't have enough evidence to say that it doesn't. So we sort of sit on the fence about it. We do some work in the lab to try and work out what that change is doing and either push it towards being a positive result or a negative. But in the meantime, we don't test anybody else in the family for it because we wouldn't want to give anyone any false reassurance if they had not inherited that. And we treat it like a negative result and again go back to the family history to give advice about risk and management. So I guess when we talk about a positive result, so finding something in BRCA1 or BRCA2, the way we manage people is a little bit different whether they've been diagnosed with a cancer previously or not. And this table, I guess, is not here to scare you, but to put things in a little bit of context for you. So for most women in the general population who have absolutely no family history of cancer, they have about a 10% chance of developing breast cancer in their lifetime, or 1 in 10 of those women develop breast cancer by chance. But if we do find a mutation or a fault in BRCA1 or 2, that risk for breast cancer increases to about 70% over the lifetime. Now, that's a very high risk, but it's a difficult concept to understand sometimes, but this risk is not evenly distributed throughout the life. So that 70% is a little bit each year that adds up all the way to the age of 85 to give us that total number, but the majority of that risk occurs between the age of 30 and 50. Women with a BRCA1 and BRCA2 mutation are always going to be at a higher risk of breast cancer than other women, but as they get older, that risk starts to drop off and approach the same risk as other women in the population. For women who have had a diagnosis of ovarian cancer, who have a mutation in BRCA1 or BRCA2, usually what we advise for you is to have mammogram every single year rather than every second year like other women in the population. Often when you hear about BRCA1 and 2 in the media, it's usually in regards to bilateral mastectomy, so surgery to remove the breast tissue before a cancer develops. But when you're already going through a lot in terms of surgery, chemo, maintenance therapy with your ovarian cancer diagnosis, we tend not to go down that path too much. The other risk is for ovarian cancer with a BRCA1 or 2 mutation. It probably doesn't feel like it sitting here in this room, but the risk in the general population is actually quite low. It's about 1% or 1 in 100. But with a BRCA1 or 2 mutation, that risk is 20 to 45%. When you've already had a diagnosis of ovarian cancer, knowing your genetic status is helpful because it means we can sometimes target your treatment with a drug that's called olaparib if you have a BRCA mutation. But it's also useful to know if you don't have a BRCA mutation because it avoids treating you with something that wouldn't have been so useful. I guess the management is a little bit different for the women in the family who've not yet developed a cancer. So in terms of breast cancer, we do offer them regular breast screening from a much younger age, usually starting at the age of 30, or there is that option of the risk-reducing bilateral mastectomy. And in terms of addressing that ovarian cancer risk, as you're probably all really well aware, there's no good screening tool for ovarian cancer. The symptoms are quite vague. And because of that, we often can't pick up a diagnosis of ovarian cancer early. And so what we do recommend for women with a BRCA mutation is that they do consider surgery once they reach their early 40s to remove the ovaries and the fallopian tubes to avoid a diagnosis. And that type of surgery does reduce the risk of ovarian cancer by about 98%. Men are also at increased risk for prostate cancer and breast cancer, so we do manage their health a little bit differently as well. So if there is a BRCA mutation in the family, it is important that both men and women are tested for it. Sorry, I know I'm really over time. So in terms of informing relatives, it can be really difficult to let them know about the results of your genetic test. But it is important that you let them know you've had a test, even if that result was negative, because that can often give them a bit of reassurance. We help you identify who in the family needs to know about this, and we can provide you with an information letter. We usually recommend taking it slow. Start with a relative that you're close with, that you have a good relationship with, and that's usually the easiest place to start. Share the burden. If you have had a genetic test, it's not your sole responsibility, even though it's your test, to let everybody in the family know. Recruit someone, bribe someone, get them to do it. Most people that you tell about your genetic test respond well. Most people are really grateful for the information, but some people can be surprised, shocked or angry, and it's just important to try and stay calm. This was really important information you thought they should know. If they have a lot of questions and you can't answer them all, they can always contact the genetic service. We're always happy to take questions and queries. And there are some relatives in your family who will choose not to have a genetic test, and it's really important to respect their right not to know, even if you really want them to. Very briefly, Lynch syndrome, something else we can test for if BRCA1 or 2, if we don't find anything and your family history indicates it. We usually see a family history of ovarian and bowel cancer in this condition, so we will test for that. If we don't find anything on testing in BRCA1 or 2, usually means increased colonoscopy, but there's no associated risk of breast cancer like there is with BRCA1 and 2. And in case anyone has looked into direct-to-consumer testing, to give you an idea of what that is, it's basically where they test a whole bunch of genes at once, so it's not just limited to BRCA1 and 2. Usually it's what we call a panel test. Only a small number of the genes included on that panel are actually associated with ovarian cancer. A lot of those genes aren't, but they may tell you about a risk of another cancer type in your family. So it's important to consider that if you found a mutation in one of those genes, it wouldn't explain your personal history, but it might give you some information about another cancer like bowel or kidney cancer, for example. And then probably most importantly is that there is a very small number of genes included on that panel that are relatively new. Because they're new, we don't have a lot of information about the risk of cancer that they cause and how we should manage that risk. So sometimes you end up with a result that you can't act on, and that can cause a lot of anxiety for people. Also, the chance of getting one of those uncertain results, that VUS, increases with the more genes we test, the greater the chance we'll get one of those types of results. And not all companies are alike. So if you're going to go down the direct-to-consumer path, it's really important to do your homework. And we do recommend discussing the results of that type of testing with a genetic health professional. And some of these companies do provide their own genetic counsellors, others don't. But you can always get a referral, and at least discussing with your GP in the first instance if not being referred on. Insurance concerns. I'd always just like to point out that genetic testing does not impact on health or travel insurance, but it does impact on what we call underwritten policies. And that includes life, disability and income protection. It won't impact on any existing policies. So when you took out that policy, if you'd not had a genetic test, you made that policy with the best information you had, which is what they call their good faith. And those policies, as long as you're paying your money, are guaranteed renewable. So they are renewed every year with the information that you initially provided. When you do apply for a new policy though, or you upgrade an existing policy or change providers, they do often ask about genetic testing results. But if you've already had a diagnosis of cancer, that's going to be the biggest impacting factor for those companies, and also age. It gets harder to get these policies as you get older. Relatives in the family who have not had cancer but have had genetic testing do have to disclose their results when they set up those policies. But even if they haven't had a genetic test, they still need to disclose any family history of cancer in first-degree relatives, so that's siblings or parents. But most of the time when we talk to people about insurance and genetics, most people proceed with testing because knowing about their risk for cancer and putting all the right management strategies in place often outweigh the concerns they have about insurance, which tend to be paying an increased premium or having limited or stipulated cover. So I know I flew through that really fast, and I'm over time, so I'm happy to take questions in the break. But in case people had any other questions or wanted to do some research, Genetic Health Queensland, you can always contact us. If you've seen us before, we're always happy to pull family files back out again and have a chat to people. Your treating specialists can also give you some information about genetics, and there's also 2 very good websites. The Centre for Genetics Education, it's New South Wales based, but it has some really good fact sheets, and so does EverQ as well. They have a section called Patients and Carers, and under that section there's some information sheets about genetic testing, not just BRCA1 or 2, but if anyone has said testing for any other genes, they're there as well. So, thank you.